Hi, Dr. Garima here, shooting a video after almost, I guess, 15 days. Had many things going on, had to tackle them as well. But anyways, I'm back here and let us start solving another clinical scenario, 6 of the ADC. For all the new candidates, this is the practice paper released by Australian Dental Council to give you a trailer of how the exam would feel like. And beautiful questions they have, especially this clinical scenario number 6. This is your almost everyday kind of a scenario, and such cases form the bread and butter of your practice, and you should know how to handle them. And let's quickly solve this before I just leave for my clinic. And yep, let's do that. So I'll be going through the process of how to solve ADC questions because they are little complicated questions and they make you use your clinical judgment. So all those students who have just finished their graduation don't have much of clinical experience. Such questions can be a little tricky for you. But if you solve it with the right attitude and the way ADC wants you to think, then you definitely can solve the question. Of course, you need to know your basics. If you don't know your basics, the basic dental subjects, that is what I mean, the way you diagnose and the steps to diagnose or treat, then you would definitely have a problem. So make your basic concept strong and then solve the question. So let's start. This is clinical scenario number 6. Miss Ibrahim is a healthy 45-year-old woman who has come to see you today regarding an abscess related to tooth 36 on your left side, first permanent molar of the left bottom jaw. She complains that she has foul taste in her mouth. That's probably because there is an abscess, and abscess is a bad taste. She tells you that the tooth feels heavy and uncomfortable, but that she has not experienced severe pain of fever or facial swelling. See, each word of the question is directing you to a diagnosis. The presence of something also directs you to a diagnosis. The absence of something also directs you to a diagnosis. Okay. So currently what this woman is saying that she is having an abscess, she's aware she has an abscess, but she says it's not that severe painful, it's not caused any fever, and that there is no facial swelling. Probably this abscess is there for a long time. Now your records confirm that you last saw Miss Ibrahim 12 months ago, that's a year, when you partially extirpated the pulp, dressed the radicular pulp with calcium hydroxide, and placed a temporary glass ionomer cement restoration. When you ask her why she did not return to have the treatment completed, Ms. Ibrahim advises that she was traveling. Alright, so probably she had some pain, she came, you decided to do a root canal, but you just started your first visit, did a partial extirpation, placed a dressing, and usually we advise patients to come back after 2 or 3 weeks, and this lady never turned back. Now, in examination today, you observed that the temporary restoration on tooth 36 has dislodged, with evidence of caries under the restoration and a chronic fistula around the Percussion area. You also take a perioapical radiograph and compare it to the perioapical radiograph taken 12 months ago. So you have 2 sets of radiographs, one which was taken when you had partially extirpated the pulp, and the one which you have taken today after a year, and you clearly see a nice radiolucent area between the roots. There is radiolucency out here, there is an abscess out here, and this restoration doesn't look that great. There is evidence of secondary caries. So basically, looking at this tooth, it's gone. You cannot save a tooth which has a Percussion radiolucency, okay, because that is an evidence that a lot of granulation tissue has formed, and there is no way you can save a tooth which is involved with the Percussion. You don't even know if there is a fracture out here, but anyways, any tooth which has Percussion involvement directly goes for extraction. Now, because you had already initiated the root canal treatment, and there is also a radiolucency out here, the root kind of becomes very weak in this area. The crown structure anyways doesn't have much of a hold. So if you try to do an extraction, even with a cow horn forceps, there are high chances that you can fracture the root. Okay, so this is one thing that you are aware of. That's why you say extraction of a root canal treated tooth is more difficult than a normal one because there are high chances of them breaking off. So anyways, this is the big scenario that we have. We have understood what it is. Now, what is the most likely reason for the difference in the appearance of the bone in the two radiograph? Most likely. That means all the options can be correct, but most likely is what we have to choose. This most, initial, best, I keep on saying in every of my video are the trap words. You have to read them and you have to choose the best option. Aggressive periodontitis. First of all, we have eliminated the term aggressive periodontitis according to the new classification. And even if you were to consider this, aggressive periodontitis is not just on one tooth. It has to be in many teeth, at least two non-adjacent teeth. You know, that's the classification. Nothing of that sort is mentioned here, so that is out. Caries. Caries is caused out here. It can be the root, but this area is not caries. This is a proper radiolucency caused by infection due to caries, agreed, due to caries, but this cannot be termed as caries. Poor oral hygiene, no. Food packing can be an option, but that is not mentioned here. Chronic localized infection. Now, food packing will not really, food packing can be the cause of creating an infection in a long term, but not all food impacted sites will result in bone loss. Okay. So the actual terminology of the bone appearance here is a chronic localized infection. I mean, these options may look weird, but pretty much they have a single best answer here, and that is chronic localized infection. Now, in addition to the periapical radiograph that you have taken today, what clinical investigation will provide you the most relevant diagnostic information regarding Ms. Ibrahim's tooth? See, what is your focus here now? After the X-ray, the next clinical examination that you would do is you want to ascertain how much deep this area is, okay? And you want to assess if there is a fracture, honestly, because that will make you prepared for the further treatment, which is extraction. So when you will probe the area, you will realize how much is the depth of the pocket that has happened, how much the percussion area is exposed, and can you actually clinically see a fracture line, or can you feel a fracture line, or if there is a fracture line, you know. So that is your next step. So here, percussion test, we already know there is an abscess. Percussion test is not of importance to us because it's already documented that there is a periapical abscess. Periodontal probing test, yes. Assessment of healthy dentine. What are you going to achieve with that? No, nothing. Crack finder test. Crack finder test is not the root fracture test. Crack finder test is on the cusp of a tooth. I don't want to see if the cusp is fractured out there. My main concern is if the root is fractured there or not, and that only I will know with the periodontal probing test. So that's the answer here, correct? You advise Ms. Ibrahim that extraction of tooth 3-6 is her best option, which is indeed a best option. She wants to know if an edentulous space can be left. So basically this lady wants to know, can I leave the space as it is? Like, I don't want a replacement, basically. What further information would be required to best assist in responding to Ms. Ibrahim's question? So if a patient comes to you and say, okay doctor, you're going to extract my first permanent molar and I have a second molar and I also have a premolar, can I leave the space as it is? So what are you going to tell the patient? The first thing you will say is, you can leave the space as it is, but the occlusion will get destabilized because the adjacent teeth which are there will start tilting, the upper tooth will start super erupting. Basically your occlusal stability will go away in the long run. That is your first answer. Then you go on to say, but we'll also have to assess the periodontal status of the adjacent teeth and the bone in that area. But the first thing that always comes to your mind is the occlusal stability of that side where the tooth is being extracted, correct? So this is what the question is asking, that what is the first thing you're going to tell that lady when she says, can I keep the space as it is? So options are aesthetic consequences. That is of not that much of an importance. Anyways, it's a molar tooth. So aesthetics is important, but in the posterior teeth, the functionality is of more importance. Periodontal status, on the IOP, it pretty much looked good, and the scenario never mentioned anything about the periodontal status. Density of the mandibular bone, that can be considered if you are placing an implant, but you can also give an RPD, you can give an FPD, in that the density of the mandibular bone would not matter that much. Status of the abutment teeth. Status of the abutment teeth again will matter when there is an FPD coming in question, but on the IOPA pretty much they look stable, so we are going to assume it's a healthy dentition. Occlusal stability, yes, that is the answer. All the options are correct, but the first thing that you will start by saying is why you cannot leave the space as it is because of the occlusal stability. The rest of the other options are secondary. You understand my point? Miss Ibrahim asks about surgical complications. What is the most likely complication that may be encountered during the extraction procedure? So now this lady has made up her mind and she's like, you know what, okay fine, you can extract the tooth, but are there any surgical complications that will happen? So the first thing what you will say is that because it's a root canal attempted tooth, there is a percussion radiolucency, the root kind of has gone weak. It can happen that during extraction, because the tooth has become weak, it can fracture. That is the first thing that you're gonna say. Spreading of infection, very less chance. Inability to obtain adequate anesthesia, again there is a possibility but not that a great chance. Damage to the adjacent teeth, well, that there are accidents that happen and of course you take consent, and in that you do mention that, but again rare chance. Fracture of the root, very great chance. Damage to the lingual nerve can happen, but again a very rare chance. So option A, B, C, E are all possible complications, but the possibility of it happening is less. It's like me telling you what are the risks of you driving a car on the road. A plane can fall on you, yes, rare chance, but can happen. A train can jump on you if you're below the metro line, yes, can happen, but rare chance. You bumping onto the another car, yeah, that's a more greater chance compared to the other two options, right? This is what the question is all about. So all the options are correct, but the first thing that can happen, which has more probability of happening than the rest of the other options, is fracture of the root. So that is your answer. And the last question for today, what is the best way to manage the extraction of tooth 36? Best way, given the presence of periapical and periodontal infection. So this question is basically saying that how would you manage the extraction of tooth 36 when infection is present? So it's a little tricky question. What the question is basically trying to say is that how would you manage the infection once you have extracted the tooth? Understood? So first you understand this question. It's like holding your nose, instead of like this, you're holding the nose like this, you know. So these kind of tricky questions which can just make you confuse are specialty of ADC. They're just trying to check your clinical competence basically. There's nothing wrong in it. But yeah, when you're solving 70 questions in a matter of 2 hours, your brain will be exhausted. That is why you have to practice solving so many questions like these, and practice solving the exam papers which I have given in my mock tests. I will explain about that to you later. So anyways, let's solve this question. So how would you manage the infection basically after extracting tooth number 36 is in between the lines. This is what the question is asking. Antibiotics 3 days prior and 2 days after extraction. Okay, now let's make one thing very clear. Single tooth abscess without any systemic manifestation. Systemic manifestation means fever, malaise, facial swelling, etc. If a small abscess is localized on a particular tooth, which is indeed the cause of the abscess, in Western countries and in the international guidelines, antibiotics are not given. I know the practice of giving antibiotics when an abscess is present, even if it's a single tooth abscess without any systemic manifestation, is very rampant in Asian countries. And probably if you are just a passed out dental graduate practicing as a locum with another senior dentist, you would also see that this is what is practiced in majority of the clinics. Then as soon as you see a patient with a small dentoalveolar abscess, the dentist is gonna write antibiotics for 5 days and then ask you to come back, or say take it for 3 days, then come back to me and then continue the antibiotics for 2 days. So somehow it's ingrained in your brain that this is a standard practice. It is not. Then you might ask why they are doing it. Well, they are doing it. There is no getting back to it, because probably this is what they learned from their practicing dentist when they were doing locum, and this is how it's ingrained in their brains. But this is not how practice in Western country operates. So if it's a single tooth abscess without any fever or something, you do not give an antibiotic. So option A, option B is out of the window. Option C, a single preoperative dose, again out of the window. It's not a prophylaxis antibiotic. The patient is not at a risk of immunocompromisation. It's not mentioned in the question. Option D and option E, curettage of granulomatous tissue and irrigation with sterile hydrogen peroxide. Can be done. Post-operative instructions including rinsing with salty water. Because it's not a huge granulation tissue, it's not a cystic lesion, you are not going to irrigate that area with sterile hydrogen peroxide after extraction. You may choose to do curettage, but I would not say you have to do irrigation. You would do irrigation if it was a cystic lesion or something. This is not a cystic lesion. It's a small abscess, and the abscess was there because the focus of infection was the tooth. But once you have removed it, the body kind of heals that area. So all you have to do is to give the patient a good post-operative instruction, including rinsing with salty water, which would be enough. That is called as a conservative management. So write it down in your notebook if you're watching this video. Antibiotics are not given in healthy patients for a single tooth abscess. Understood? So this is what it is. And how do you perfect yourself in the preparation for ADC exam is by solving as many practice past papers which is provided in my mock test, by strengthening your basic dental subjects which are provided in my books, Ultimate ADC Companion book and Comprehensive ADC book. ADC exam is 70% of your dental subjects and 30% of therapeutic guidelines, ODL, infection control, ethics, motivational interviewing. All these things are not textbooks, like they are resources provided by ADC and you have to study them, and 30% of questions are asked from them. So very important, 30% is quite a lot, right? So and the passing percentage is less, so you have to be like really thorough in marking your answers, and that can only happen if you practice and practice and practice. Do not be overconfident that because you know dentistry you can clear the ADC exam, you'll just keep flunking and you'll just getting frustrated, because this exam is conducted only twice a year and it's an expensive exam and the study material is huge, so a lot of time you have to devote, so you obviously expect a good result. So be very, very grounded and study properly. As much as you will practice, the more confident you will be there in your exam. So you can watch my other videos to understand more about how to solve questions. So we have finished scenario 6. Tomorrow we'll do scenario 7. And if you have any questions, you can leave it on the comment. If you would like to have a sample of my books, the Ultimate ADC Companion book and Comprehensive book, you can just drop me an email on adcwrittenmocktest@gmail.com and I would be happy to share the sample copies. And you can also join the Facebook group Target ADC, where I keep sharing a lot of questions, and it's a good community of 5,000 plus dentists who are appearing for the ADC exam. So have a nice day. See you all later. Bye bye.